Bismillah ar-Rahman ar-Rahim. We'll start the session now. It is my pleasure to introduce Dr. Sergio Vano Calvan, who will talk about my treatment approach to androgenetic alopecia in men and women. Please, Dr. Sergio, the floor is yours.
Well, good morning to everybody. Thank you very much for the invitation to that interesting Congress, and it's my pleasure to visit Dubai. It's always very interesting to visit that amazing city. Thank you so much. Well, so we are going to talk about my treatment approach to androgenetic alopecia and men and women. These are my disclosures. And before starting the lecture, I always love to start the presentations with this summary of my work. This is my team. I'm very lucky because I direct a group of 23 dermatologists focused on hair disorders, both in the public hospital, Ramon y Cajal Hospital in Madrid, Spain, and in the private clinic. And I have to thank you them because some of the articles that I'm going to discuss have been published by them. So first of all, some special features of the hair disorders consultation. The first one is like the importance of the monitoring with pictures, because the patients usually forget how they were at the beginning, and if you don't have like the macroscopic pictures, it's sometimes difficult to evaluate the effectiveness of the therapies. Of course, as dermatologists, I think one differential diagnostic tool is the trichoscopy, and I think that every patient with a hair disorder in the consultation should undergo a trichoscopy, and this non-invasive technique has been a revolution in the hair disorders field. The third one is the empathy and patient information. Sometimes the patients with hair disorders can be a little bit heavy, you know, but we have to be empathetic and think that they are really affected, and their quality of life can be really involved with these diseases. So I think that it's important to give them the proper information and not not decrease the importance of the disease of the patient, of the alopecia. And also it's crucial to individualize the treatment strategy, because the treatment success will mainly depend that the patient performs and the patient has a good compliance. If you propose a therapeutic strategy which is like not really interesting for the patient will stop the treatment and you will not succeed. So I think this is really, really important. It's not the same, these two androgenetic alopecia in female patients. The first patient is a patient with a 35-year-old woman, extremely affected by her alopecia, and she wants to do everything. The second one is a 45-year-old woman that is very concerned about side effects. So even with the same degree of androgenetic alopecia and the same profile of patients, we would not prescribe the same treatment in one or the other. It would depend also on the preferences of the patients. And also we have to manage the patient's expectations. This is the curve of improvement after a hair transplantation. I mean, you have to explain to the patients in androgenetic alopecia that they will start feeling the improvement after 4 or 5 months, not after 1 or 2 months. So if you don't give this information, the patients can start the treatment with minoxidil, for example. They can start with shedding, and they can say, oh, I'm not improving, I'm even worsening. And if you have not told it, they will be really unhappy. So it's important to explain to them when they will start feeling the improvement. In fact, I usually exaggerate a little bit, like you are not going to feel improvement until 6 or 7 months, and they usually feel a little bit earlier, so they come to the consultation really happy. Well, so let's review a little bit of new articles and important therapies that we will summarize in the therapeutic algorithm. This Delphi consensus about the management of low-dose oral minoxidil has been recently published. You know that this therapy, in my opinion, is one of the most important in the last 10 years for androgenetic alopecia. And in this Delphi consensus, it was stated that this is a safe therapy. This is a treatment that doesn't require like monitoring with different tests. It doesn't require a specific test prior to the treatment. So, I mean, it confirms that the group of experts worldwide give their opinion that this treatment can be used. It's an off-label treatment yet, but can be used with these doses, a higher dose in men, lower doses in female, because they can develop hypertrichosis, which is the most frequent side effect. And conclusion, low-dose oral minoxidil is safe, effective, off-label treatment for the majority of alopecias, but talking about androgenetic alopecia, of course, for men and women. treatment. I can remember, I go back in the slide a little bit, because I can remember when I started using oral minoxidil was after an American Academy of Dermatology Congress in Washington that I started to listen to the lectures of Rod Sinclair, which is the pioneer from Melbourne, Australia. It was in 2016, so 10 years ago. Times flies. So we started using this in Spain, and it was really, really amazing. And it's incredible how in 10 years it has become one of the treatments of choice for a lot of alopecias and of course, for androgenetic alopecia. Well, this is one study that we could publish, a multi-center study, which is like the largest series regarding the safety of oral minoxidil, 1,404 patients, and we saw that only 1.7% of patients had to stop the treatment due to side effects. So 98% of the patients tolerated the treatment, and there were no severe side effects, and we could observe that there was like a chronological pattern of appearance of the side effects. The cardiovascular side effects were like early side effects after a few days after the beginning of the treatment with oral minoxidil. On the other hand, the hypertrichosis and fluid retention were like late side effects, and they appear between 1 and 3 months after the beginning of the treatment. This is important because when we prescribe, for example, low-dose oral minoxidil for female patients, we recommend the patient to increase the dose every 3 months, because if after 3 months the patient has not developed hypertrichosis, it's really, really not very probable that she will develop. So that way you can increase the dose very slowly to avoid these side effects. Well, this is the summary of the side effects of the study. As you can see on the right-hand side of the slide, the numbers are really, really small compared to the large sample size. The most frequent side effects was hypertrichosis, followed by fluid retention and tachycardia. But I insist that all these treatments, all these side effects were like mild, and the majority did not lead the discontinuation of the treatment. And for hypertrichosis, for lightheadedness, dizziness, we can give we can adopt some measures like hair removal for the hypertrichosis, or we can take or prescribe low-dose oral minoxidil at bedtime to decrease the risk of lightheadedness. In fact, a good point for fluid retention, for example, and to avoid hypertrichosis in female patients taking low-dose oral minoxidil is the combination with the androgen receptor inhibitor spironolactone, or even bicalutamide. It can decrease the risk of hypertrichosis. So this combination, spironolactone and oral minoxidil, you will see is our treatment of choice for premenopausal female androgenetic alopecia. In this series, one colleague of our team published like a series of hypertrichosis induced by a low-dose oral minoxidil, more than 100 patients, mild in the majority of cases. And what is surprising is that 40% of the patients, of the female patients, were not concerned about having a little bit more of hair in the face. The most frequent side were the sideburns. And in the remaining patients, only 4 patients discontinued the treatment due to this hypertrichosis. I mean, in Spain, when we start this treatment, we tell to the patients that if they feel a little bit of hypertrichosis, it's not worrisome. We can manage the doses. Worst case, we can recommend an epilation method, or worst case, we can decrease the dose or stop the treatment. But it's totally reversible, so it's not usually a problem. Well, we have seen the safety of low-dose oral minoxidil in patients without comorbidities, but what about patients with hypertension? Because 1 out of 3 adults has hypertension, and in this study we also analyzed a number of patients with hypertension under antihypertensive treatment that we prescribed low-dose oral minoxidil, and only 2 patients required adjustment or discontinuation of the antihypertensive drug. And this is like the summary of the side effects in this cohort of patients, and it's really quite similar. The 1.5% of patients stopped the treatment. This is quite similar to the 1.7% of the general population. So, well, it's interesting because when we analyze the data from a statistical point of view, there were only 2 factors that suppose that increase the risk of systemic side effects: the use of doxazosine, a direct vasodilator, and the use of 3 or more antihypertensive drugs. In that profile of patients, be careful. In the rest, we talk to the cardiologist and so on, and we publish these recommendations that we can prescribe low-dose oral minoxidil in patients with hypertension under antihypertensive drugs without any problem. Just only be careful in patients with taking doxazosine or 3 or more antihypertensive drugs. Well, let's follow with some new therapies, androgenetic alopecia. We published this high-dose oral minoxidil. We call that way patients taking even 10 milligrams, 15 milligrams, and the majority of patients, they wanted to take it. In fact, we didn't prescribe that such high dose, but they took it, and we observed that the effectiveness increased and the side effects increased a little bit, but not so much. So in some patients, especially if they have hypertension, we can go even to 15 or 20 milligrams daily. Of course, if you increase the dose very slowly, the risk of systemic side effects were lower. Well, we have other articles regarding low-dose oral minoxidil. It can be used also in patients older than 65 years old. The only issue here is that if you prescribe every other day, the risk of systemic side effects is a little bit higher, but you can prescribe a low dose in a daily way. And of course, there are other treatments that we publish in this Delphi consensus from the Spanish Hair Research Group. And we know the majority of the treatments are off-label. And in this article, very recently, we describe our way of treating the patients. We are going to move to the algorithm because our therapeutic algorithm is for male androgenetic alopecia, we prefer oral dutasteride. We know that it's off-label in the majority of countries, but it's much more effective than finasteride, and it has the same safety profile demonstrated in meta-analysis. We use oral minoxidil as a first-line treatment, and in some patients we add topical minoxidil. But with this, managing the doses of oral dutasteride and oral minoxidil, we can treat the majority of our patients very successfully. Of course, there are other therapies or other situations that we can use other treatments, second-line treatments, like topical finasteride, like mesotherapy with dutasteride, platelet-rich plasma, new treatments like botulinum toxin, which I don't like so much, but microneedling, low-level light therapy. But the mainstay of treatment in male androgenetic alopecia for us is the use of oral dutasteride plus oral minoxidil. What about female patients? Well, the same, oral minoxidil, first-line treatment, plus, in some patients, topical minoxidil, and we usually prescribe oral anti-androgenic drugs. And there, we distinguish premenopausal patients, we use spironolactone or bicalutamide, and postmenopausal, we prefer a 5-alpha reductase inhibitor, mainly dutasteride. I'm going to go through all the animations. These are like the exceptions of what we have seen, because there are some patients, for example, with signs of seborrhea or signs of hyperandrogenism. In that patients, we prefer bicalutamide over spironolactone. But this is quite easy, the treatment for the patients nowadays. With oral minoxidil, we can manage the patients only with oral therapies. Well, finishing, I don't want to extend because we will be on time. Just only 2 articles that reassure us regarding the use of 5-alpha reductase inhibitors in women with a personal history of breast cancer. According to that articles and to the scientific evidence, 5-alpha reductase inhibitors, dutasteride, finasteride, do not increase the risk of a recurrence of breast cancer. This is something really important, these articles with a high sample size. And let's talk a little bit about dutasteride. I like this molecule. It's more potent than finasteride, has a long half-life. So if you prescribe 2 pills of 0.5 dutasteride per week, it's equivalent, according to that clinical trial, to finasteride 1 milligram daily. So it's really interesting. We can use dutasteride as a maintenance therapy. We published this study. Of course, the patients treated with daily dutasteride, they improve a lot, and only 3% require discontinuation of the drug. But what is more interesting is that we treated a cohort of patients with low-dose oral dutasteride, like 2 or 3 capsules of 0.5 milligram weekly, and 2 out of 3 improved, and no adverse effects were seen in that profile of patients. Well, dutasteride is amazing. Many patients come to the consultation requesting a hair transplantation. We start with oral dutasteride, and after 1 year, they are really happy and they don't need the treatment with the surgical treatment. And I don't want to finish without talking about trichopigmentation. It has been one of my recent discoveries, and it's amazing. It's like between the medical therapy and the surgical treatment, we can combine this with the surgical treatment, and the result is really, in some cases, really good, and it can avoid the surgery in female patients that want to increase the hair density, and after some treatments, medical treatments, they have not improved as expected. Well, I will finish with some of our patients treated with different medical therapies, and sometimes the improvement is really amazing. When you see with trichoscopy this patient, for example, you can see that he had like a lot of miniaturized hairs, so this is could predict that the response could be good, and that way the response was really good. And after these first treatments, the patients we use like a maintenance therapy to increase and to improve the compliance of the patients. But the message that I wanted to finish is that the medical treatment in androgenetic alopecia is really the most important part, more than the surgical treatment, and that all the patients that will undergo surgery should be under medical treatment. Well, last 2 slides and last 14 seconds. So I'm very happy to invite you all to the World Congress for Hair Research in Madrid. We will hold it in Madrid in May 2028. You have the dates here. You are really invited to come. And thank you again for the invitation for this nice Congress. I'm really grateful. I hope this has been useful for you. Thank you.
Thank you, Dr. Sergio. And if there is any questions, you can put it in the app, and it will be answered by the speaker on the application, on the conference application. Okay, so what is your management for men with dutastride intralesionally regarding pregnancy? Should they wait before making their wives pregnant?
Well, interesting question, the management of anti-androgenic drugs in men and women regarding pregnancy and regarding fertility. I'm not going to extend, but regarding that question, so mesotherapy with dutastride, the absorption of dutastride is really very low. So there's no problem at all with men receiving this mesotherapy with dutastride. And for women, it would not be a problem, but from a medical legal issue, we recommend the same as if the women were taking oral dutastride, like to not having pregnancy during the treatment and 6 months after the last session of mesotherapy with dutastride. But when the man is the one who is being injected, there's no problem at all.
Second and last question for now. Okay, so the other questions will be answered after, I mean, on the application, because of the time.
Thank you, Dr. Sergio.
Thank you, Doctor.
Thank you.
So now we'll move to our next speaker, Dr. Michaela Staros. She'll talk about trichoscopy in alopecia areata.
So good morning to everyone. I'm very happy to be here also this year in this wonderful Congress. And we move to talk about the stageways trichoscopy in alopecia areata. You can see in this list how it is so important today to approach also alopecia areata with trichoscopy, because it is very helpful to help you to decide the therapy, to decide the activity, and then also to better monitoring the patients. You have always to start to look at the patient with the clinical evaluation, but it is not only the SALT score that today can help us to decide the therapy. Then we have also to put all the other important information as the association disease and the quality of life. At the end, we need to have the clinical evaluation. We have to be sure that it is an alopecia areata, especially in diffuse form, with all the most important tools as trichoscopy, pool test. In very doubtful cases, you can use also biopsy. You have the second, identify the type and the gravity, the severity of the alopecia, and you can help with the clinical examination, with the SALT score. But if you want to identify the activity of the disease, you need not also the pool test, but especially the trichoscopy. When you have a patient, the trichoscopy approach is also different on the basis of the clinical aspect. So you have in front of you a different patients with a different presentation as a scalp or face, as only hair brown, hair lashes, and it's important to decide at the end the therapy on the basis of this severity. So surely you have to start with the SALT score that is today very important to decide how it is involved your scalp with alopecia areata, that is severe or not, if it is more than 50% of the scalp involvement. Then you have to use the scalp score to understand also if it is a candidate maybe to the new therapy as the JAK inhibitor. But at the end, you can use also the clean raw score, where you can look at it it with a hair-brown misuration, and you can on the clinical approach. Then you have to move with the clean row or the eyelashes again. And don't forget at the end of your evaluation also to look at the nail involvement, because it is very frequent, especially in severe form, in adult, but especially in children. And it is very important because the quality of life it's very reduced in this type of patients. Then we have, after the clinical evaluation, move versus the pool test. As a trichoscopy pool test, it's important to perform not only in the area of the alopecia, but also in healthy scalp, because it's important to understand if it is the activity is higher. And it is important also with trichoscopy, because it is possible to find some typical trichoscopy sign in not apparently clinical evaluation of alopecia areata. Then use trichoscopy especially for characteristic explanation of the pathogenesis to identify the activity. And it is important to understand where it is important to approach your trichoscope in the diagnosis of and the monitoring of alopecia areata, because you can use trichoscopy to understand when it is the best time to stop the therapy. So don't forget in all your patients to look at not one patch, but to look all around all the diffuse patches. So put it or trichoscopy in the, especially in the inside the patchy area at the periphery to understand the activity and the progression, but also in healthy scalp, because only in this way you can understand really what it is the involvement of the scalp due to alopecia areata. You can do it at the diagnosis, but also at the follow-up to monitoring the response of the therapy, because it is very useful not only for the diagnosis that until now and from the past alopecia areata is a clinical diagnosis, but also to evaluate the activity and show again the result. This is an example you can see where trichoscopy can be very different. You can see in the different part, even if the scalp area involvement is with this big patch that is at the center with the chronic phase versus the other activity at the periphery. So there is a progression, but also we can find some sign also in healthy scalp. Trichoscopy today, the updated, confirmed the role of trichoscopy to identify the activity. You know that the most important sign are the yellow dot, the black dot, the circle hair, and exclamation point mark here that are pathognomonic of alopecia areata. And these are important, especially to understand the activity. In fact, in case of acute phase, you have to recognize the typical black dot together with the broken hair and exclamation point here. Yellow dot, it is possible to find in both activities, so in acute, but also if there is the only sign, it is specific of chronic phase. And then there are some important signs of the regrowing phases. The black dots are especially these fracturate hair that remain inside the empty follicle. It is an acute damage of the hair matrix, and it is the residual that is fall down due to at the level of the follicular unit. You can see in some pictures are very similar in a lot of diseases, are not specific of alopecia areata, but today it's very easy to recognize it in different form. When there is a grow, even it is possible to find also activity. They are very helpful for the diagnosis, but especially to indicate the progression of the alopecia areata. In case of a broken hair, so dystrophic hair, we have this broken hair at a different length with the uniform of color and diameter. With the black dot, they indicate an acute form. They are important, but are, again, not specific or alopecia areata. We can find also in tinea capitis, lichen planopilaris, and so on. Exclamation mark hair are a subacute form of alopecia areata. They are very important because they are pathognomonic. They indicate a previous damage that reduces some part of residual of the hair in the follicular, and there is a new hair that starts normally without an activity. And it is the residual of the previous hair. You can see for this reason, the distal part that is darker versus the proximal part that is lighter. And you can see some example, again, very, very easy to recognize. They are very important, and they are possible to have this sign, very diffusely sign, multiple, that is name is Paul Pincus constriction. And the other important sign is the yellow yellow dot. Yellow dot, it is an empty follicle with a yellow discoloration due to the presence of the sebium that is inside of the empty follicle. Its presence is different from alopecia areata, but don't forget that it's alone is a typical sign of chronic form. You can see it is identical on a pathology of a case of alopecia areata. You can see some example. Again, you can have especially the yellow dot in a very small patchy area, because in this case it's very difficult to distinguish only with the clinical application. If you look at it with the yellow dot with your trichoscopy, you can see the typical yellow dot, so you are sure about the diagnosis. You can see it's very helpful for the diagnosis. And finally, we have the short hair. The short hair can be a sign of regrowing phases. We can have two types. The nanogen hair that is regrowing, but they are stopped. There are a mild inflammation on the scalp that reduce the possibility of a complete regrow, or the typical circle hair that is a remission. You can see the pictures. This is the typical values here, can be also regular, can be circle, versus the nanogen that can be not ready to start a new hair. And in any case, they are a good prognostic sign due to therapy. The circle and pigtail hair can be a sign of another disease. This is a variant of alopecia areata. They are a sign of mild inflammation, and they are a sign of a subacute form. And this is typical of alopecia areata incognita or diffuses. You can see some slides that you can recognize that are typical of no patchy form of alopecia areata. And also the circle hair that are typical of regrowing, very good prognostic factor after the therapy of alopecia areata. See, trichoscopy can be very useful also to understand the prognosis. You can understand the acute phase, so you can tell the patient that in the future can be worsening before to have the result, versus the chronic phase. And so you can decide also the therapy. In case of a diffuse form, in case of acute form, the most important indication is steroid therapy. Versus the case of chronic with only the yellow dot, you can decide the topical immunotherapy or the decision versus the JAK inhibitors. Don't forget that if a clean row, it is applied with the trichoscopy, it's very easy to recognize not so very high level of inflammation. With the trichoscopy, you can see black dot. So you are sure that it's not a reduced form of clean row. This is another example. You can see here the involvement of the hair brown, and you can see a very acute form with a lot of exclamation mark here. It is possible also in eyelashes in these cases. You can see with the clinical and with trichoscopy, where you can see a very great involvement of the eyelashes by alopecia areata. And this is with the high magnification, typical exclamation point. You can see another example. You can look at it with the clinical, and you can see with the trichoscopy that you can have a great variability and great visualization of the sign. Here, it can be not involved by alopecia areata, but if you can see with trichoscopy, you can see a lot of yellow dots. So very useful. Don't forget to use at the end also to look at the regrowing of after the therapy. You can decide to stop the therapy, as in these cases, with a complete hair regrow. On the other side, also with the complete SALT score. In the other SALT, there's a picture. If you stop now, there is the residual of some activity. So you need to continue the therapy before, even if the clinical is completely regrowing phases. We also create this severity trichoscopy score index of alopecia areata. You can count in the different part, you can see this table, and at the end it can be very useful to understand the rapid and comprehensive assessment of the activity, and in this case to select the best therapy in each patient. So in alopecia areata, in the diagnosis, you can do always, but there are at the end some important form that is very difficult to distinguish, and in this case, if trichoscopy can be very useful, you can need the biopsy. And these two forms is the long-term, the long-lasting form, and especially the diffuse form of alopecia areata incognita and diffuses. The pathogenesis, it is explained now with the trichoscopy, and it is important to use it with acute versus the chronic form. Also because you decide the therapy. In acute form, again, the first choice is steroid versus the chronic form with that are you sure with the trichoscopy. You decide maybe in adult or in children a different therapy. Don't forget to use the expert consensus to decide the therapy and your decision also in the clinical, but especially with trichoscopy. Trichoscopy is very important today in alopecia areata. It will be an important tool at the end to decide how it is better the management of our patient. Thank you for attention. If you want to have a complete course on demand on trichoscopy. Thank you.
Thank you so much. If there are any questions for Doctor. Just if you have any questions, you can place it in the app so we can view it on the screen. Okay. Thank you so much. No questions for Doctora.
Okay,
Thank you so much.
Now it's my great pleasure to introduce Dr. Sergio again. He is giving his second lecture, which is titled Treatment Successes in Scarring Alopecia, How I Did It. Dr. Sergio, floor is yours.
Thank you so much. So let's go with the other types of alopecia, scarring alopecias, and I really liked when the organization proposed me that title. It's really interesting, Treatment Successes in Scarring Alopecias, How I Did It. So, well, I'm going to present 3 cases and talk a little bit about some tips. We have time. So this is the first case. So this is a frontal fibrosing alopecia in a patient that was really affected by this loss of the temporal area. So we performed a hair transplantation, and she was absolutely happy after 1 year of the hair transplantation. And this is something that makes you reflect that sometimes in frontal fibrosing alopecia we focus on the medical therapy. We give like hydroxychloroquine or dutasteride, topical JAK inhibitors, PRP, and I mean the expectation of result is not to worsen, not worsening, you know. And for the patients, many times they look for an improvement, and these kind of improvements, even if they are not long-term improvements, they can really improve the quality of life of patients. We published this multi-center study about the outcome of hair transplantation in FFA patients in 51 patients in the Journal of the American Academy of Dermatology, and it reflects what we are seeing in clinical practice, that the hair transplantation in FFA is not the best scenario to do hair transplantation. So for a hair surgeon, it's not like the best patient, but the patients really are really happy after the hair transplantation. 82% of the patients were satisfied with the procedure, even if after 3-4 years they started to lose the follicular units, the grafts, and they only had 40% of the transplanted hairs after 5 years. So when I receive a patient and she asks me or he asks me about hair transplantation, I explain this to them, like, okay, this is going to last about 4 or 5 years, and it's that way. Even if we perform the medical therapy, some patients can stay longer, but it's, in my experience, a good point to talk to the patients. And the majority of patients say, okay, doctor, there's no problem. I go to the other doctor of the clinic to receive Botox every 6 months, so I will perform another transplant after 5 years. I mean, if the patient has enough donor area, it can be done. Of course, we don't recommend very big hair transplantations, so we usually perform this kind of temporal areas transplantation, but I wanted to focus on the cosmetic measures and measures that can improve the quality of life of patients, because, for example, the micropigmentation of the eyebrows is like something that we recommend in the first visit, and it improves the quality of life of patients in a dramatic way. And it's very important what I said at the beginning, like in the first visit you have to explain to FFA patients that the objective of the treatment is that they don't worsen. So I usually say, if in 5 years you are the same as today, it will be a complete success. Because if you don't tell that, the patient will come next year and you will ask, how are you? And she will say, no, I'm very bad because I'm the same. So you have to explain that they are not going to improve. Of course, they can improve with some measures that we are going to summarize in the next slides, but this will be like the surprise for the patients because not all the patients can obtain this improvement. In patients like very late, long-standing frontal fibrosing alopecia, grade 5 of 5, I mean, we should recommend like weeks or like cosmetic measurements. They are very easy measures. I discovered these kind of measures by the patient. So this young patient with FFA, this is the eyebrow. She had a complete eyebrow loss. This is the trichoscopy. What is the diagnosis? Only 8 euros. It will be 8 plus 4, 32 dirhams. Oh, I think so. These are stickers sold on Amazon. So it's amazing. They are like the shape of men, women, and this gives to the patient like an idea of how micropigmentation can be. And these really easy measures really improve the quality of life of patients. And of course, the trichopigmentation, we talked about it. They can even avoid the surgery in some patients. So I think that we, as dermatologists, should approach the patient in a 360 degrees way, explaining all the medical therapies, even when to recommend surgery, but also these cosmetic measures that many patients will be happy. At that point, like talking about FFA, I wanted to give you like a brief summary of one technique that I think is very important in hair disorders and also in frontal fibrosing alopecia, which is like the injection of corticosteroids for different hair disorders. Well, yes, I'm going to summarize like some personal tips in the treatment of FFA. So in FFA, we are using less and less the injections of triamcinolone. Why? Because they are usually not required. We can use topical calcineurin inhibitors, pimecrolimus mainly, or tacrolimus. We are using less and less also topical steroids because of the atrophy. But in some patients, we can use injections of triamcinolone very diluted, like 2 to 4 milligram per milliliter. And if the patient has a little bit of atrophy, we can even combine in the same session with PRP. PRP, I'm not very fan of PRP for androgenetic alopecia, but I'm really a fan of PRP for some cicatricial alopecias, and mainly for frontal fibrosing alopecia. Is that kind of procedure that you don't see a lot of difference in the pre-post picture, but the patients are really happy. They feel like some changes in their skin, and they even decrease some symptoms like trichodynia or pruritus. So, I mean, we are using more and more PRP. It's true that we don't charge like very expensive for that patients. It's kind of research, but I think it's a really interesting measure for combining with triamcinolone injections. Well, this would be like the current therapeutic algorithm for frontal fibrosing alopecia, updated on 2026. Our idea is that we prescribe a treatment for decreasing the inflammation, mainly topical pimecrolimus, and in some patients we can prescribe like oral treatments like hydroxychloroquine. It's very trendy, the use of topical JAK inhibitors. In Spain, they are approved for vitiligo, and they are like really expensive, and I think that they don't have any advantage over the classical anti-inflammatory treatments. For us, and based on the scientific evidence, we should give a treatment for preventing the disease progression, you know, because it's not clear, and it's very interesting that some patients with a lot of inflammation, they remain stable over time. I have patients with a lot of inflammation on trichoscopy that they are completely stable with the measurements and with the pictures in the last 10 years. And on the other hand, we have many patients without any inflammation that they worsen despite the medical therapy. So I think that the main outcome, the patient usually doesn't care if he or she has a little bit of redness or not. What they want is that they don't want to lose their hair. So I think that this second part, this second group of treatments is really important. And in fact, it's quite controversial because based on the scientific evidence, 5-alpha reductase inhibitors, specifically dutasteride, is the treatment that can achieve a higher degree of stabilization. Why? Well, there are different hypotheses. It's not completely known, but the truth is that based on the case series, is the treatment with a higher degree of success. So we try to use in almost all patients. And don't forget the treatments for improving the aesthetics or some specific features that we are going to see in a summary slide. And the surgical treatment, not for all patients, but for selected patients, if they understand that the duration of this hair transplantation is not for a long term, it can be an interesting option. We published this, this protocol in the Blue Journal a few years ago, and it's very easy because with this topical pimecrolimus, oral dutasteride and oral minoxidil, we can stabilize 70% of the patients. Of course, it will depend on the pattern. You know that the article of the pattern 1, 2, and 3, the worst pattern is the pattern 2, the diffuse frontal fibrosing alopecia. In that case, we should be like more intense, more potent with the treatment, while the pattern 3 is like the good prognosis pattern, and that way we can be not so potent with the treatment. But this is quite interesting. These are what treatments we can offer to the patient with FFA to improve some feature and that they will be really happy. So oral minoxidil will improve the hair density in many patients. Oral isotretinoin will improve the facial papules and also the rosacea, which is like very frequently associated. PRP and vascular laser, they will improve the atrophic skin, the facial veins. Oral naltrexone, gabapentin for the symptoms, hair transplant for the hair density, other aesthetic measures like eyebrow and scalp micropigmentation or the wig. So I think that as dermatologists, we have to give advice to the patients regarding how they can improve. Well, let's move to the case 2, and they will be like shorter than the case 1. And this is my worst complication of hair transplantation. Raise your hand, please, the one of you who performed hair transplantation in your clinical practice. Raise your hand. Who is doing hair transplantation of you? Okay, like not a lot of people, so I will show you this, and with this case, please don't be disappointed with hair transplantation, but it's really interesting. This is a patient, she was like the CEO of a luxury brand of jewels, and she was operated with a BCC, a plastic surgeon, and the plastic surgeon performed a skin graft. You know, this is a secondary cicatricial alopecia. Well, and she came to the consultation, what can we do, and so on. Well, I was really like positive and optimistic. We performed the hair transplantation. She had androgenetic alopecia, so we got the advantage to also increase the hair density in the frontal area. But, well, the patient went on holidays to the hair yacht in Montpellier, and, well, she sent us these pictures that were really not really optimistic with this crust. She came to the consultation. We removed the crust, and she had like this wound with the bone exposed. So, and the patient was like, "Doctor, when I will be able to return to the yacht tomorrow?" I said, "So we are going to try to improve it. We had to operate on her with an advanced flap." The patient, we explained to them. We were writing to them all the every day almost, and after 3 months, you know, it's very usual that they develop this hair loss, this telogen effluvium after the hair transplantation, and also because of the surgery. Imagine, it was dramatic. If I would have been the patient, I would have, I don't know, demanded me or so on, but she was even like more worried about my worrisome about her. But fortunately, after a few months, you know, after the hair transplant, after 6 months, the transplanted hair starts to grow, and then this is the final, result after 9 months. I could breathe after these months, and the patient was really happy. But the important thing is that in that kind of complications, you have to be like close to the patient and behave with him or her the way that you would have liked that the doctor behaved with you. Well, and let's move to the third case, and it's like regarding lichen planopilaris. There's other measures to improve the hair density, oral minoxidil. I'm very grateful to Rod Sinclair because he has been pioneer with oral minoxidil that we prescribe to almost all the patients that come to the hair disorders consultation, and also patients with cicatricial alopecias like lichen planopilaris. If they have diffuse lichen planopilaris, they can improve with this drug, with oral minoxidil. Even some patients with PRP, with lichen planopilaris, they can even regrow hair if the hair loss is quite recent. So, we can think about the treatment of lichen planopilaris with different therapies rather than the usual ones. Of course, when we have like an advanced lichen planopilaris, we should think about wigs. The FAST system is a kind of wig that will improve the quality of life of the patient. This would be like the therapeutic algorithm, treatment for decreasing the inflammation. The majority of the patients with LPP, we use topical steroid and intralesional steroids every 3 months. We prescribe oral minoxidil, and depending on the symptoms and so on, we we use other measures. And of course, the surgical treatment is more or less like in frontal fibrosing alopecia. Many patients will have benefit from them. Well, I have included folliculitis decalvans, like the therapeutic algorithm, if you want to take a picture, although I'm not going to talk about folliculitis decalvans, but I think it's another interesting cicatricial alopecia. In Spain, the most frequent cicatricial alopecia, without doubt, is FFA, followed by LPP, and followed by folliculitis decalvans. So this is typical of young men in the crown, you know, and this is the treatment that we usually perform. And just to know, there's like a recently described like chronic form of folliculitis decalvans, this chronic lymphocytic phase that resembles like a lichen planopilaris, but it's folliculitis decalvans, and the treatment is more or less like lichen planopilaris. Well, I think that this was like more or less the same information that I had before, so I'm going to advance to be on time. And just only to summarize, just to say, I don't know if is here my good friend Hassan Galadari, because Dubai is amazing. I always love to come to Dubai. You know that Dubai is going to be one of the candidates for the World Congress of Dermatology 2031. I support Dubai, and I would love that it's in Dubai. The thing is that I'm the secretary of the candidacy of Madrid for 2031. So with my good friend Hassan, we will be in all the places, but I will be really happy if it's in Dubai because, I mean, Spanish people, we really love Dubai. So thank you very much again for the invitation, and thank you to all. Thank you.
Thank you, Dr. Sergio, two informative lectures. We have one question. You can see it on the screen from case 2 regarding the side effects of hair transplant. What was the diagnosis of the lesion post-transplant? Did you give oral minoxidil to help with hair growth in the area?
Well, in hair transplantation, is already known. It's not a complication. It's like a normal evolution of the transplanted hairs that you transplant, you perform the hair transplantation, and the follicular units that you have transplanted fall down after 1 or 2 weeks, and then the hair root, the stem cells, remain below the skin and start to grow after 5 to 6 months. And the curve of improvement achieves its maximum after 1 year. So I usually tell to the patients, especially to the female patients, like, because, you know, if we don't shave the head of the patients, the non-transplanted hair will develop a telogen effluvium because of the microtraumatisms of the hair transplant. So this is something normal that after 3 months, the patients are worse. I usually tell them, for them not to forget. So you are going to hate me after 3 months. In 6 months, you will be like very neutral, but after 1 year, you would love me because they will like really have the improvement. But this you know, like joke stays in the head of the patients because after 3 months, this is due to a telogen effluvium induced by the microtraumatism. So this is absolutely well known, and it's not a complication. It's something normal about the evolution. It's like in mine, like when you inject Botox or you have an inflammatory phase of a few hours, or depending on the injected product. So it's something which is normal.
Thank you, Dr. Sergio.
Thank you very much.
Our next speaker is Dr. Michaela Strasser, that she will give a talk about the efficacy of skin patting and iontophoresis with dutasteride gel in male and menopause female androgenetic alopecia. Please, Dr.
So thank you again, and we have here again to talk about this study about efficacy of skin pathing iontophoresis with dutasteride gel in male and menopause female androgenetic alopecia. And this type of technique, it is included today in the list of physical therapy, where you can see other important therapy that we started to use a lot of years ago, so as the laser therapy, the PRP, the microneedling. The use today of this type of technique is especially to induce a faster improvement, to delay medical therapy, especially in mild cases, and to stop hair loss as soon as possible. In general, the physical therapy are very important today. It's an important tool that we can use in a lot of diseases, but especially in telogen effluvium and in alopecia, androgenetic alopecia. where maybe the patient not decide to start a therapy for a longer time from the beginning, when the cases are very mild, when you have children in front of you, wherein it is so possible to start each type of therapy. The goal of this therapy is not only to stop the loss, but also to encourage the regrowing in a very fast way. And then today, there is also the necessity to start a therapy that are especially not invasive. And for this reason, we start to use a different technique as iontophoresis, as sonophoresis, the microneedling, the PRP, use it again, the mechanical trauma. And in this way, we start to use this technique that the name is trichopath, where you can see the association of multiple aspects together in the same devices. In our cases, we study this device, especially for the mechanical part, due to the presence of controlled microdermal incision, and also together the second part with the transdermal delivery. The use of iontophoresis today is very important, is an important tool without any invasive way to arrive directly on the scalp of the patient. And to arrive at it today, the iontophoresis, it's a very great way to absorb a lot of the gel that is possible, like growth factor, as a drug, as a dutasteride, tacrolimus, triamcinolone acetonide. So you can use this device in a lot of multiple diseases, and without any side effect due to the presence of or absence of the absorption in the systemic way. And the trichopath, in fact, it is a combination of different diseases, different parts, where it is important to combine these two aspects, the skin patting, so the microdermal incision, together with the iontophoresis. It's a non-invasive way to arrive directly on the scalp, on the derma papilla, due to the presence of two parts. In the first part, we have the mechanical trauma with the presence of the microdermal scalp incision that are enlarged at the periphery of each side with this pressure way. On the other side, we have in the second part the iontophoresis. Before the start of the two parts, we have always to apply a gel that is select on the basis of the type of the disease of our patients. We move the typical skin pattern that is this microdermal incision that induce an injuries and require and recall your growth factor to repair these injuries. In addition, you can apply the gel of growth factor, dutasteride gel, to also penetrate inside the scalp. On the other side, we have the iontophoresis, where we have the relaxations. So we have the vasodilatation and vasoconstriction of the muscle of the capillaries, which enhances so much of the vascularization on the scalp. And then we have the electronic way to reduce immediately also any sensation reported by the patients. Today, in fact, iontophoresis is the first method that is approved for the most important absorption of each substance versus also the minimum aspect of the side effect that is a mild skin irritation. So there are a lot of advantages that with the use of iontophoresis, because you can use different topic, different drug, different in a very simple way with a very good compliance of the patient, because any pain is reported by it. The agent you can use with the skin patting and iontophoresis today, they are a lot, and a lot of publications are on PubMed that report the role of this technique. But we can use today trichopathing in alopecia, androgenetic alopecia, to have faster and better outcome, and also in patients that are not so happy about the result with maybe 1 year of the therapy. You can use, in fact, in mild form of androgenetic alopecia, especially with growth factor, but also in case of a moderate form with the use of dutasteride. This is the first study with the use of growth factor, and I have a very great experience with a lot of patients. And in these cases, we can show some result of the study with a male patient or a female patient, with a great result after 6 months with 4 sessions. But in this study, we try to use dutasteride, that you know very well after the Sergio talks, how it is so important today, the use of anti-androgen in androgenetic alopecia. In this study, we can collect female menopause women, because the problem of absolutely fertile women are not possible to use anti-androgen, and also male patients. And you can see in this study of 20 patients how we have a very great result. In female patients, you can see this experience with dutasteride, and in male patients. Don't forget that all these patients that I showed without any therapy at home. It is only the role of 4 sessions, 1 each month after 6 months. And you can see, especially on trichoscopy, how it is so important to have this result. And they decide not to start any therapy after this session. You can see a lot of results in different type of patients that are enrolled in this study. And you can see in male, but also in female, with a very high level of the number and the diameter of the hair. There are 4 sessions where it is especially the first session to reduce the symptoms. In the second session, we start to reduce the hair loss. In the third, they start to initiate the regrowing phases. And finally, the third session is to fortify the result. So today in androgenetic alopecia, you can use this type of technique, especially to induce the hair regrowing, to stop the hair loss, but to enhance the hair diameter. And the goal is to enhance the number of the hair that emerged at the same follicular unit that after, with the use of drug as a dutasteride, they return completely at the normal diameter. So today, the use of dutasteride gel with this technique in androgenetic alopecia, you can use in mild form who cannot want to start a medical therapy for all their life. In moderate severe form, also in addition of a medical therapy at the beginning or after 1 year with not enough result. It's a very pleasant method. It is very appreciated by all the patients, and they never denied and never stop any session, especially for the pain that is never reported by them. And also you can use it all over the scalp. So for me, this type of technique in androgenetic alopecia is very useful in mild form, in moderate form. So I think it is a very good option, especially without any painful sensation during any therapy. And thank you for attention.
Thank you, Dr. Michaela. We will not have questions because of the time and the prayer time. It will be answered on the application if any questions are there.
Thank you.
Thank you so much. It's with my great pleasure introducing Dr. Azzam Al-Khalifa, who will talk about the diagnostic value of nail clippings. The floor is yours, Dr. Azzam. If you have any question, please, you can post your question in the app.
السلام عليكم ورحمة الله، سعد الله مساكم بكل خير. سعيد جدا بالعودة كل عام لهذا المؤتمر، يعني مؤتمرات اللي pure scientific, pure medical, we learn a lot, and with great experts from all over the world. I will talk about nail clipping. You see these pieces of the nails that you throw. They are full of information. We will come through them in the dermatology and even beyond. Of course, it's better than biopsy when it comes to the pain. But it's not more, it's not more representative. You cannot use it as a replacement of a biopsy. But I think this is coming because biopsy is very painful. The healing time is longer compared to clipping. Just you clip it and that's it. Anesthesia takes time and it is painful sometimes. Kids, old age. It is not easy compared to clipping. Then you have the risk of scar because when you are doing a biopsy, you are doing it on the matrix. And of course, there is always a risk of scar, whether it is a punch biopsy or a lateral longitudinal biopsy. So if we can use clipping as a mirror, if we use clipping as a mirror of the matrix, because the matrix is represented by the nail plate. And we know that the top surface of the nail plate is the proximal matrix, the lower part of the nail plate is the distal matrix. So if we can use this part of the nail to give an idea about what is happening here, this will be very helpful in the clinic. Imagine in your clinic, a patient with old age, or a young patient, or even a regular patient with something, yellow nail, you don't know if it is psoriasis, it is onychomycosis. You just do clipping and you have your diagnosis. It is much easier than a biopsy, but it's not effective compared to the biopsy. This is an example of a patient, yellow nails. You think, is it psoriasis? Is it onychomycosis? You can do a biopsy. It looks like psoriasis, but you can do a biopsy or you can do clipping of the nail plate. In this kind of patients, it would be helpful to recognize the diagnosis. This is an example, a published case, of a patient with the yellow nail of the big toenail. It looks like onychomycosis, but it could also be psoriasis because there is the erythema surrounding the onycholysis, and it is yellowish, so it could be both. In the histology, you find nail thickening, you find subungual debris, and you find parakeratosis and some neutrophils in the biopsy, here and there. So parakeratosis, neutrophils, thickening. Another patient, here more looks like psoriasis, and in the biopsy we see the same thing, nail thickening, subungual debris and keratosis. You see parakeratosis and a lot of neutrophils. So same presentation. The first was onychomycosis, and the second was psoriasis. So they have the same signs. But in this interesting study, a retrospective study of more than 100 patients, they analyzed the histopathology of nail clipping in patients with onychomycosis and psoriasis. And here we have neutrophils, scattered aggregated collections, just like mild, moderate, severe, and we have parakeratosis also. They found that in onychomycosis, you have more patients with severe or more neutrophils in onychomycosis compared to psoriasis, where there was aggregated neutrophils but not collections. So more neutrophils in onychomycosis, but more parakeratosis in psoriasis. So this is the main, this is a difference when it comes to histopathology, but the main difference is the PAS stain. If you do the PAS stain and you see the hyphae of the fungi, this is confirmative of the diagnosis of onychomycosis. So the three differences are the PAS stain and more neutrophils in onychomycosis, but less parakeratosis. And even when you have a patient with onychomycosis and you just do clipping for culture or KOH, you see in these studies, 4 different groups, 4 studies, the sensitivity of histopathology is 82% versus 53% with the culture. 88, 33. Imagine sensitivity 33 with the culture. So 2/3 of the patients where you do clipping for onychomycosis is a false negative. They might have onychomycosis, but the culture is negative. While for histopathology, it is more sensitive, very sensitive. 93%, 88% sensitivity. So you can't replace the culture except for the price. It is more pricey. But the histopathology with PAS 10 is much better than culture alone. You can do culture and KOH, and you can do, in my practice, I do culture and KOH. If both are negative, and I still think it is onychomycosis, I redo clipping for histopathology. And if it is negative, it is not onychomycosis. So it is much more sensitive, but you have to take it from the right place. Because if you do clipping here in the distal nail, there is no stain of Trichophyton rubrum. It is not orange here. So there is no living fungi here. But you have to do it proximally to get the fungi to be more representative for histopathology and even for culture and KOH. Try to do the clipping proximally. The distal clipping is not very helpful in onychomycosis. So this is the first use of nail clipping. We can make a diagnosis of onychomycosis and confirm it with clipping. We can suggest the diagnosis of psoriasis with only clipping without doing a biopsy. The second use of clipping is for melanonychia. Here you have 7 different patients, and I will let you think. Look at the pictures and think which one of them is pure melanocytic. How many of them are pure melanocytic, nevi or melanoma? The first one, do you think it is melanocytic? Yes. The second one? Could be. No, because this is surface alteration. Here, well, purple and red. This is a hematoma. This is clear. The fourth one? Yes, no. What it could be? Proximal? The proximal part is not pigmented, so it is only the distal part of the matrix. Okay, and here, same thing because the proximal part. It could be a nevus of the distal matrix. Could be. Here, yes, and here, could be. So we only have one melanocytic case. Only this one was a nevus. This one was onychomycosis. Pigmented onychomycosis, and we know that there is evidence that some fungi produce melanin. One of them is Trichophyton. So this was pigmented. And you know, in our skin type, we see these cases a lot because our skin type nails are easily pigmented. So you see here is pigmented onychomycosis. Here is pigmented onychomatricoma. It was in the beginning. Here it was hematoma. Here it was pigmented onychopapilloma, and usually exactly onychopapilloma starts from the distal matrix. Here it was pigmented onychocytic matricoma. Here it was nevus, and here it was pigmented squamous cell carcinoma. So in our skin type, we can see all of this. So a lot of pigmented cases, but with clipping, you can know if this is melanocytic or not, if this is melanin or not. So here are the diagnoses, we talked about them. Compared to hematoma, it is very easy. You can do the stain for blood, the diaminobenzidine, or the Fontana stain for melanin. But even in cases with melanocytic pigmentation, melanocytic melanonychia, sometimes you hesitate, is it benign, is it malignant? Here it is broad. There is Hutchinson or pseudo-Hutchinson. We don't know if it is malignant or benign. So can we use clipping for these cases? Not always, but we will show some cases where we can suggest the pigmentation as malignant melanoma. Here, it was a case of atypical melanonychia with xanthonychia. Was it onychomycosis or melanocytic? We don't know. They started with a clipping, and they found it was melanin, but they found also cellular remnants in the distal nail. It is not normal to find cellular remnants here in the distal nail. Cellular remnants are in the matrix or close to the matrix. But finding cellular remnants in the distal nail, they suggested that it is not benign. And they did a avulsion excision, and they confirmed that it was subingual melanoma. They knew it from the clipping, starting with the clipping without doing a biopsy. Here is another condition, different case, not pigmented. This is erythronekia with onycholysis, and they didn't know the diagnosis. They started doing clipping to know what is it, what is the nature of the lesion. And in the clipping, they found also cellular remnants of melanocytes. With the HMB45 stain, they found melanocytes. So there was cellular remnants. They were wondering if it was a malignant melanoma. And they did the avulsion excision, and they confirmed that it was amelanotic nail unit melanoma. So from the nail clipping, but for these cases, you really need an excellent histopathologist by your side. Not any histopathologist can help you with that. You can collaborate with one histopathologist to train him and to take a benefit from his excellent knowledge. So without an excellent histopathologist, you cannot make a diagnosis of melanoma out of this nail clipping. Onychomatricoma, very easy with the dermoscopy and with the clipping. You can see the cavities filled with serous fluid, and with stain, they are lined with epithelium. Onychopapilloma, also clinically you can see that it looks like onychopapilloma. There is the subingual keratosis, and you see in the clipping that there is also the subingual keratosis here and the thinning of the nail plate, typical onychopapilloma. But they saw an atypical onychocyte here. There was an atypia in the onychocytes, and they thought that it could be malignant onychopapilloma. So they did the excision, and it was confirmed that it is malignant onychopapilloma. With the stain, you can see the clear cut of the lesion, of the malignancy here. So from nail clipping, they could know, but again, you need an excellent histopathologist. So from dermatology, we talked about these: onychomycosis, psoriasis, melanoma, onychopapilloma, malignant onychopapilloma. You can use the clipping. Out of dermatology, just 3-4 slides. You know that the glucose, blood glucose can glycate proteins, and that's why we test hemoglobin A1C to have an idea about the chronic level of glycemia. But in this study, they did nail clipping, and they analyzed it with mass spectrometry after liquidation, and they found that the protein furazine, which is a glycated protein, they found that it was equivalent to hemoglobin A1C taken within the last 3 months. So from the nails, they could know the level of the glycemia. But within the last 3 months, you know that hemoglobin A1C tests the glycemia within the last 3 months, and then 3 months later, you do the nail clipping. So the nail clipping gives you an idea about the glycemia within the past 6 months. So it is more talking than just the hemoglobin A1C, but it is still in the beginning. I think it is coming, but it is more difficult in the lab. It is easy in the clinic, but it is more difficult in the lab. Also, thyroid hormone, they can have an idea about the chronic level of T3 and T4 with the same assessment spectrometry. Cortisol and testosterone were also tested and confirmed to be accurate from the nail clipping. So all hormones, cortisol, testosterone, thyroid, glycated proteins also from the nail clipping. Medications, you can assess the compliance of the patient. In forensic, I'll not talk a lot about it because, you know, they can test the DNA from the sublingual material. And arsenic poisoning also can be found in the nails as in the hairs, but more chronic in the nails. So you can test a longer period with the nail clipping. Lastly, drug addiction. Alcohol, nicotine, cannabis, opioids, cocaine, and amphetamines. They all can be found, and they represent the exposure within the past 2 to 5 months. I talked previously about this, and all people were wondering about testing men or testing women if they have addiction before marriage or before like military job. This could be used, but it is not easy to be tested, so I don't think it is available everywhere. Last minute, last slide, and this is a very important, I like this study. They analyzed the nail clipping of newborns. They took the nails of newborns, and they divided them into 2 groups, group 1, group 2. Group 1 were the newborns abandoned by their families, and group 2 were the regular newborns with stable families. And they tested for drugs to discover if the mother used drugs during pregnancy or not. And they found that in the regular newborns or stable families, 0%, 0%, 0%, almost 0, 6% of these drugs, cocaine and morphine, methadone, all these drugs. But in the abandoned newborns, they found up to 25% of the drug use, which means that the mother used drugs during pregnancy. They also assessed for caffeine and smoking. And you see in the regular and stable families, when the mother said, yes, I smoke during pregnancy, nicotine tested positive in the nails of the newborn. So they could find nicotine and caffeine in the nails of the newborns when the mother used these smoking or a lot of coffee during pregnancy. With this, I conclude. I think that clipping is much, much easier, but we are still in the beginning. I hope this will replace biopsy, at least for some of the diagnoses. And with this, I conclude. Thank you very much.
Thank you, Dr. Azzam. Actually, because the last speaker cannot attend because of some emergency, we have the time for questions for all Dr. Azzam and for all speakers, if you have any questions. Then, if there is no question, yeah. Yes, there is a question. Yes, Doctor. Dr. Azzam, there is
Dr. Azzam, one question.
A question for you, Dr. Azzam, yes.
This was actually a very interesting and informative talk. Could you just tell us briefly how you perform the procedure? I mean, how we can do it in the clinic, just briefly. Thank you.
The procedure of clipping?
Yeah.
Just cut the
Is
nail.
it as simple as just taking a clipping with the nail clipper?
No,
or
it's just the regular clipping, but they need at least 4 millimeters for the lab to...
how do you preserve a dry sample you send it for analysis?
I couldn't hear, sorry.
Do you use any transport medium or you just send as a dry sample?
Well, I start by alcohol swab. I cut the distal nail, and then you send it in a sterile vial to the lab, and they will do all the rest.
Thank you.
No. I send it in a vial, and they put it in the media. I don't send it in a media. I don't have medias in my lab, in my clinic.
Okay.
There is a question that
One more question.
Thank you, doctor. So you mentioned that for some cases we have to hunt for certain signs, like for the onychomycosis case, you mentioned that we have to be a little bit proximal than distal. So what are the techniques for that?
Sorry, I cannot hear well here. I don't know if you can hear, but
repeat
if
it,
you are
Dr. Ahmed.
asking about the proximal or distal clipping to test for onychomycosis,
Yeah, the technique for proximal clipping.
we'll try to do the most proximal possible. You cannot reach the most proximal, but don't just clip the distal and send it. Actually, you need the colored onycholysis because there is the stain of the fungi. And if it is dry, you see the powder, subungual powder, there is the area or the keratin where the fungi feed. So try to take some of the powder for the culture. I mean, some of the doctors, they just clip the distal and send it, and that's it, and they get a false negative of the culture. So just try to get proximal, try to get some powder, try to cut more proximal, and you will get a representative culture and histopathology.